Welcome to The Explainer, where we break down complex topics into clear, actionable insights. 20%. Just let that number sink in for a second. That's the mortality rate for a common medical emergency if it's left untreated. So today we're diving headfirst into two really high-stakes clinical scenarios where your next move, well, it isn't just important, it's absolutely critical. Okay, let's dive right in. Picture this. You're on call. Two patients come in, both with acute agitation. Now, on the surface, they look completely different, but here's the thing. They are both in crisis, and it's your job to cut through all that noise, figure out what's really going on, and start the right life-saving treatment. No pressure, right?
So first up is case file number 1. We've got a 45-year-old man. He's just been admitted to the medical ward, and he's agitated, he's confused, and you can just see it. He is absolutely terrified.
And then his wife gives you that one piece of history that changes everything. He's been a heavy drinker for 20 years, and he stopped cold turkey just 3 days ago. Bingo. And now, he's not just paranoid. He's literally drenched in sweat, and he cannot stop shaking.
Okay, now this is where the pieces of the puzzle really start to click into place. What we're looking at here is a textbook picture of autonomic hyperactivity. I mean, his fight or flight system is just going completely haywire. His blood pressure, heart rate, temperature, they're all through the roof. And check out those electrolytes, the low potassium and magnesium. That's super important because those are the things that can really fuel dangerous heart problems, just like that brand new atrial fibrillation we're seeing on his ECG.
All right, so you've got all this data staring you in the face. What's the one thing you have to do right now to pull this guy back from the brink? Just take a second and think about it. What's the move that actually gets to the root cause of this whole crisis? And the answer is C. You know, the really crucial thing here is using a structured, symptom-triggered protocol. Why? Because it's not a guessing game. It allows you to systematically tackle the withdrawal itself, adjusting the meds based on how severe his symptoms are moment to moment. We're not just trying to calm him down. No, this is about preventing life-threatening seizures. It's about saving his life, period. What we're seeing here, folks, is classic delirium tremens, the DTs. And let's be crystal clear. This is a full-blown medical emergency. I mean, the timeline is perfect, right? It's been about 72 hours since he stopped drinking, and now his entire nervous system is in open revolt. We have to intervene, and we have to do it methodically and right now.
This slide is so important because it shows you the common traps. The other options aren't just wrong, they're actually dangerous. You give him haloperidol, you could literally trigger a seizure and make his heart rhythm even worse. Phenytoin? It just plain doesn't work for alcohol withdrawal seizures. And giving benzos just as needed, man, that's like trying to put out a forest fire with a water pistol. It is nowhere near enough. Okay, let's switch gears completely onto our second case. And this is a whole different ballgame. We have a 32-year-old woman. Her husband brought her in, and her crisis, well, it couldn't look more different from our guy with DTs. So the story is she stopped her lithium about 3 months ago. And why? The classic reason. She was feeling fine. But now she's been on these epic shopping sprees. She's got these grandiose plans to launch a global tech company from her living room. The key difference here? She's not scared at all. She is on top of the world, totally euphoric. So you can see the clues are pointing in a totally different direction. Yeah, her vitals are a little high, but nothing like the red alert we saw with our first patient. No, the real story here is her behavior. That grandiosity, the speech that's so fast you can barely keep up, and of course the smoking gun. Her lithium level is basically 0. This is a pure psychiatric emergency. So when you see this kind of high-risk behavior, and you know she needs to be stabilized fast, what's your move? What's the most appropriate thing to do for her right now? And the correct answer here is B. It's a 2-pronged attack, and that's why it works. First, oral olanzapine, that's an antipsychotic that's going to start bringing those manic symptoms down, and it's going to do it quickly. Second, urgent admission. This part is absolutely non-negotiable. We have to protect her from herself and the potentially devastating fallout of her actions. Yeah, this isn't just someone in a really good mood. This is a severe manic episode. Her judgment is completely gone, which makes her a real danger to her own life and well-being. So the whole game plan has to be about 2 things: getting those symptoms under control fast, and making sure she's safe in a place where she can't cause any more harm. This chart really drives home the point about timing. It's everything in this situation. Look, long-term, she needs a mood stabilizer, like lithium or valproate. That's the foundation. But right now, they are way too slow to kick in. You can't wait a week. We need a bridge to get her to a safe place. And that bridge is the antipsychotic.
So let's pull back for a second and look at the big picture. We've just walked through two wildly different emergencies, right? One is mostly physiological, the other is psychiatric, but are there core principles that tie them both together? You bet there are.
It really all boils down to this simple 4-step checklist. Step 1, you have to control the symptoms, and you have to do it urgently. Doesn't matter if it's benzos for withdrawal or an antipsychotic for mania, that's always job 1. Then you move on to addressing the root cause, preventing the immediate complications, whether that's seizures or financial ruin, and through it all, the number one priority is keeping that patient safe.
So, here's your high-yield summary, the stuff you absolutely have to walk away with. Delirium tremens is a medical emergency, full stop. Use a structured protocol with benzos. For severe mania, your mantra should be fast-acting meds and safety first. And please, remember that stopping lithium cold turkey is just asking for a relapse. It's almost a guarantee. Okay, so you've got the playbook now for these two really tough situations. You've made the right first call. But here's the thing that separates good from great. It's always thinking about what's next. Your patient is stable, for now. So what else is on your differential? What other zebras do you need to rule out? Asking that question, well, that's what clinical excellence is all about.